Hello, everyone. My name is Bridget R. Pascual, an infection control practitioner from the Michael Garron Hospital IPAC Hub. Welcome to the 8th lecture of the LTC CIP lecture series, Antimicrobial Stewardship. Here with us today are 4 amazing infection control practitioners from the University Health Network IPAC Hub. Without further ado, here are Bella Prodan, Stephanie Fedsin, and Chantal Williams.
Hello, everyone. My name is Bella, and I'm an infection control practitioner with the UHN Hub. I have a background in nursing and social work. So without further ado, I'm going to go ahead and share my screen with you. And here we are. So we are going to be talking about antimicrobial stewardship. So we'll just get right on with it. I'm just going to minimize this here. Perfect. So we have a wonderful quote here that basically starts off our presentation. So the World Health Organization ranks antibiotic resistance as one of the biggest threats to global health. As antibiotic resistance grows, we run the risk that simple infections like a scraped knee or strep throat could once again kill. This is from a University of Waterloo professor, Brett Barrett. And I will get right into it. So our objectives for today will be to review the core elements of Antimicrobial Stewardship Program. And throughout the presentation, we will be calling it ASP for long-term care. With this, we will be recognizing the fundamentals of antimicrobial susceptibility. Next, we will review the antimicrobial susceptibility and applications. Under this, we will understand the basic of antimicrobial susceptibility and have knowledge of the clinical application of antimicrobials. Next, we will review the basic principles of colonization, infection, and contamination. We will define colonization, infection, and contamination. We will also recognize appropriate antimicrobial use and potential harms. Within this, we will comprehend the importance and principles of diagnostic stewardship. So just a little bit of background here for you. Residents are more prone to infections in long-term care due to comorbidities, institutional exposure, invasive devices, and age-associated changes. On average, 6 to 10% of residents will be taking antibiotics at any given time. Antibiotics are the only medication that can impact other residents through the development of antibiotic-resistant organisms, AROs, and C. difficile. Studies show that 40 to 75% of antibiotic prescribing may be unnecessary. Next, we'll be talking about the core elements of Antimicrobial Stewardship Program in long-term care. So Antimicrobial Stewardship Program, it is a collaborative, coordinated programs and interventions designed to improve antimicrobial prescribing. With this, we have the right drug, dose, duration, and route of administration when antibiotics are needed. Optimize clinical outcomes while minimizing unintended consequences of antimicrobial. Antimicrobial stewardship programs have been shown to improve patient outcomes, reduce antimicrobial agent-related adverse events, and decrease antimicrobial resistance. These programs improve infection cure rates and reduce treatment failures for the optimal safety outcome by ensuring the correct diagnosis and confirming the correct antibiotic, verifying the correct dose and the optimal route, implementing an antibiotic timeout in 2 to 3 days to evaluate if the diagnosis is correct, recommending debridement and source control. In the case of transfers to an acute care facility, the acute care facility would administer the antibiotic. However, the long-term care IPAC lead knowledge of the medication, dose, and time administered would be helpful in the event the resident develops a post-operative surgical site infection. These are the core elements of antimicrobial stewardship. Up to 70% of nursing home residents receive 1 or more courses of systemic antibiotic in a year. And if we look over on our right-hand side, we can see the 7 core elements. They are leadership commitment, accountability, drug expertise, action, tracking, reporting, and education. In the next few slides, I'll be going over in more detail for every single one of them. So we can start off with our first core element, and that would be leadership. Including ASP efforts in written statements and sharing this commitment with staff, residents, and families. Including ASP-related duties in the position summary of medical directors, nursing leadership, and pharmacists. Communicate prescription policies, expectations, and maintain accountability for those policies and expectations. Supporting a culture and activities that promote ASP. This is what makes for good leadership. Our next core element is accountability. Identify and appoint key individuals accountable for antibiotic stewardship activities. Some of these individuals in your facility could be medical director, director of nursing, consultant pharmacist, infection control practitioner, so your IPAC lead or IPAC manager, console laboratory, and public health. Our next one is drug expertise. Establish relationships with consulting pharmacists or other individuals with the antimicrobial stewardship training or experience. Examples of these would include working with consulting pharmacists with specialized training, partnering with antimicrobial stewardship program leads at hospitals within the referral network, developing relationships with infectious disease physician consultants. Our next one will be action. Improving the evaluation and communication of clinical signs and symptoms when infection is first suspect. Situation, background, assessment, recommendation. This is our SBAR tool. Optimizing diagnosis testing, for example, to collect a urine culture, and requiring an antibiotic timeout for all new antibiotic start. So this is to see the effectiveness and if we've gotten the right bacteria. Okay, the next one will be tracking. The facility must monitor at least one process and one outcome measures of antibiotic use. By determine if antibiotics are prescribed per policy, so your process measure, tracking the amount of antibiotic use to review patterns of use, and determining the impact of stewardship efforts. Outcome measures include days of therapy, antibiotic start, and prevalence surveys. The lastly will be monitoring clinical outcomes. And finally, we get to our reporting and education. Reporting. The long-term care facility provides regular feedback on antibiotic use and resistance to prescribing clinician, nursing staff, and other relevant staff. Education. Provide resources to clinician, nursing staff, residents, and families about antibiotic resistance and opportunities to improve its use. Examples. It will be flyer, pocket guides, newsletters, electronic communication, and face-to-face discussions. This could also be an automatic messaging or emailing system. Okay, so I have here for you our first question of the presentation. So which of the following statements about Antimicrobial Stewardship Program is false? A, ASP program reduces treatment failures through several mechanisms. B, ASP programs help ensure the right dose duration, and route of administration when antibiotics are needed. C, ASP program aim to stop prescribing of antibiotics. And D, ASP programs decrease antibiotic-related microbial resistance. So I will give you a few seconds, a few minutes, and we will go on to the answer. So for everybody out there, if you've answered C, that is the correct answer. So ASP programs aim to stop prescribing of antibiotics. ASP programs do not aim to stop prescribing of antibiotics. They aim to improve it. So we know that this statement is false out of the rest of them. So we want to improve this. We don't want to stop it. Okay, and we will be going over to question number 2. As the ICP for Rose Hill Long-Term Care, you implement a new urinary tract infection program to optimize diagnostic stewardship and reduce antibiotic overprescribing in your home. The program involves auditing when urine cultures are obtained and providing feedback. Which core element of the ASP program does this activity best reflect? So we remember our 7 core elements. So we have 4 right here. Which one do you think it is? A, leadership, B, action, C, drug expertise, and D, tracking. Again, you can take a few seconds or minutes to answer. And if you've answered B, you are correct. So the answer is action. While all elements of a good ASP program can facilitate the implementation of a UTI program, the action element is specific to implementing interventions. And with this, I will leave you and I will hand the presentation over to my colleague, Stephanie, who is a nurse practitioner and works with our UHN hub with infection prevention control and the microbiota therapeutic outcome program. Thank you. Stephanie, all yours.
Thank you, Bella. I'm going to discuss now the antimicrobials and understanding susceptibility and applications. So first, we're going to talk about defining what antimicrobials are. So antimicrobials are substances that are capable of killing. These are known as bactericidal, or inhibiting. These are known as bacteriostatic microorganisms. And this includes bacteria, fungi, viruses, and parasites. Some of the antimicrobial agents include antibacterial, and these are known as antibiotics. And it's highlighted here because it's the most commonly prescribed antimicrobial in long-term care. Also, next is antivirals, which is second most commonly prescribed in long-term care, followed by antifungal and antiparasitic. When we think about antibiotics, we should consider the harms associated with them. Some of these include anaphylaxis, C. difficile, which is an infection associated with antimicrobial use, oral and vaginal superinfection. This can be due to a disruption of the flora and most commonly causes candida or a yeast infection, and that can be in the oral or the vaginal or rectal area. Adverse drug reactions, increased healthcare expenditures, resident and family suffering, potential heavier workload burden, unnecessary diagnostic testing, toxicity. For example, gentamicin might cause autotoxicity. Unfavorable public perception of a facility with increased infection rates, related costs and burdens of adding transmission-based precautions, so adding on different extra precautions, and increasing the risk of multi-drug resistant organisms, also known as AROs or MDROs, colonization and infection. The consequences of an infection with an MDRO is largely based on the fact that these infections are more challenging to treat and often require antibiotics that are more difficult to obtain or costlier. The result of this is prolonged and costlier treatments, which makes sense, extended hospitalizations, people generally are sicker or require longer therapy, additional use of healthcare resources, so manpower, equipment, getting the drugs, and greater morbidity and mortality rates. So people who are sicker have higher rates of perishing from these diseases or have permanent disabilities from them. Because the consequences and harms associated with MDROs and antimicrobial prescribing are so significant, the AHRQ, which is the Agency for Healthcare Research and Quality, has created 4 moments of antibiotic decision making. These are 1, making the diagnosis. So does the patient actually have an infection? Are there signs and symptoms of an infection? Do they make the criteria for deciding of whether or not they have an actual, for example, UTI? Number 2 is cultures and deciding if you're going to have empiric therapy. We'll discuss the meaning and application of empiric therapy in the next slide, but basically here it's obtaining the cultures and deciding whether or not we're going to treat. Number 3 is selecting a duration of therapy. Generally, the recommendation is to select a short duration as is safe and effective. This is to limit exposure to antibiotics. And finally, number 4 is to stop, narrow, and change to oral. I think this last step is a good reminder to review your cultures and ensure that the most narrow drug is being selected. So now we'll discuss the uses of antibiotics, or the intention of antimicrobial use. Here we'll see prophylactic. Prophylactic is the administration of an antimicrobial to reduce the likelihood of infection or severity of disease if infection occurs. The patient has risk factors, but does not actually have an active infection. An example of this might be starting Tamiflu on a floor prophylactically to reduce the incidence of infection or reduce the severity if someone does develop an influenza infection. Number 2 is empiric. Empiric therapy is utilization of an antimicrobial, like an antibiotic, to treat an assumed infection without knowledge of what's actually causing the infection. So we don't have the microbiology results from the culture to confirm the pathogen, but we're going to treat it anyways because we know it's an actual infection. For example, a urinary tract infection that is very convincing signs and symptoms, we should probably start them. In the next slide, we will discuss the role of the antibiogram and how it influences the selection of empiric therapy. Finally, we'll discuss therapeutic antimicrobial use. And this is when an infecting agent is known and we have the susceptibility results. And we're able to guide treatment based on what the culture and sensitivity says. So this therapy is targeted. An example of this would be narrowing the spectrum of antibiotic for the pathogen found in a culture, such as transitioning to macrobid to treat a UTI that is caused by susceptible E. coli. Next is the antibiogram. So when we're discussing empiric therapy or empiric treatment, we don't know what the causal pathogen is. And many times we need to start treating the infection before we don't have the time to wait for the culture and sensitivity to come back, and we need to start treating the pathogen more urgently. This is when an antibiogram may be useful. So antibiograms are reports that summarize common pathogens and their antibiotic sensitivity for a specific setting, such as an LTC. This is because susceptibility can vary within different populations. So the antibiogram provides information regarding local susceptibility patterns. So what's local to your LTC or geographic area. They're an effective tool that clinicians can use to guide prescribing, and they enable clinicians to make prompt, empirically based decisions based on what is the common sensitivity in that area. And finally, they help reduce prescribing of antibiotics with high local resistance rates in these settings. So if there's a pathogen that's very resistant in the setting, we're not going to be prescribing it appropriately. So here we are, we have an example of an antibiogram, and this is a susceptibility report. On the left-hand side, you'll see a list of the organisms. And on the right-hand side, you'll see the percentage of isolates that are susceptible to that particular antibiotic. So if we look at E. coli on the top of the organism list and follow it across, we can see that it's 97% of isolates are sensitive to fosfomycin. So that's presented in the green box. However, only 54% of the isolates are sensitive to ampicillin. So that's a yellow box. Interpreting cultures and sensitivities. So this is important when we have our sensitivity back to look at what does susceptible, intermediate, and resistant mean. A susceptible bacteria is a bacteria that's inhibited in vitro with a therapeutic concentration of an antibiotic. So for example, the usual dose of the antibiotic will likely work. So the normal dose of macrobid, for example, will probably produce a acceptable clinical outcome. Intermediate is when the bacteria is inhibited with an antibiotic concentration that has an uncertain therapeutic effect. So this is where the zone of inhibition is not quite large, and we'll talk about the zones of inhibition in the next slide. There might be a need to increase the dosing. It doesn't necessarily mean that this bacteria is resistant, but we might have to change the way we administer the antibiotics. Oftentimes, prescribers will opt for a susceptible antibiotic rather than going with intermediate susceptibility. Finally, we have resistant. And this is where the concentration required to inhibit the organism in vitro has a high likelihood of therapeutic failure. So there might be drug resistance here. And that's where we don't see a good bactericidal or bacteriostatic effect for the antibiotic at all. So it's probably not going to work in a clinical setting. When we're looking at measuring microbial sensitivity to antibiotics, we normally look at what's called a DISC, and there's a couple of methods available to evaluate this. There's the Kirby-Bauer DISC diffusion test, automatic antibiotic susceptibility testing. I don't think these are as important for the LTC exam, but it's helpful to know what they are. You'll see on the right-hand side, there's an agar-agar plate, and there's these discs of antibiotics that are in them. The plate is inoculated with a bacterium, and then the discs of the different types of antibiotics are placed on the agar-agar plate. And you'll see the circles around it where the bacteria is unable to grow or penetrate is called the zone of inhibition. And it surrounds the antibiotic disc. In the center, you'll see a nice, healthy, large zone of inhibition. This likely represents an antibiotic that has good effect on the bacteria. So that bacteria would be sensitive to that antibiotic. On the bottom, you'll see the disc has a smaller zone of inhibition. This is where the bacteria is able to grow a bit closer towards that antibiotic disc, resulting in a smaller zone of inhibition. And this is probably representative of an intermediate result. And finally, on the left-hand side, you'll see that disc there with almost no zone of inhibition. And this represents resistance. So this is likely a resistant bacteria. We would not want to select this antibiotic for this bacteria. And then finally, in summary, it's important to understand the bigger picture when prescribing antibiotics. And multi-resistant drug organisms are not just a long-term care issue. This is One Health model, which is introduced from the World Health Organization, is an integrated and unifying approach to balance and optimize health of people, animals, and the environment. It's particularly important to prevent, predict, detect, and respond to global health threats such as COVID-19 pandemic. We should always keep in mind where our place is in the bigger picture across many settings, and how we're both influenced by others and how our actions influence others as well. Okay, let's go on to question number 3. George is a resident at Rose Hill Long-Term Care Home on an influenza A outbreak floor, and he recently developed a cough and fever. His respiratory swab has not yet resulted. The nurse practitioner has just started George on the full treatment dose of Tamiflu, or oseltamivir, 75 milligrams twice daily. And this is to treat a presumed influenza infection. What type of antimicrobial prescribing does this reflect? Is it A, prophylactic, B, empiric, C, therapeutic, or D, inappropriate? I'll let you pause now, James, or whoever's hosting, and go ahead and answer. Okay, so the answer is B, empiric. Empiric treatment refers to the treatment of a presumed infection when the infective agent is not known. In this situation, the nurse practitioner has presumed that George contracted influenza based on the symptoms and the situation of the outbreak, but we don't actually know from that PCR swab that he has confirmed influenza. So this would be empiric treatment. Question 4. Which of the following statements are false regarding antibiograms? A, antibiograms provide information about local susceptibility patterns. B, antibiograms may help reduce antibiotic prescribing in communities with high resistance rates. C, the use of an antibiogram replaces the need for a culture and sensitivity testing. Or D, antibiograms are mainly used by prescribers for empirical treatment and not therapeutic treatment. I'll let you go ahead and answer now. The answer is C. The use of an antibiogram replaces the need for culture and sensitivity testing. This is not true. Using antibiogram with empiric treatment of infections. However, a culture and sensitivity is still important to identify the causal agent and ensure the best selection of antibiotics. So the antibiogram does not replace the need for a culture and sensitivity testing. Okay, I'm going to hand it over to my esteemed colleague, Chantal Williams, who is an ICP in Infection Prevention and Control, to discuss colonization, infection, and contamination. Thank you.
Thank you, Stephanie. Hi, everyone, and I'm going to be taking you through colonization, infection, and contamination. So let's get started, and we'll start off by defining them. So contamination is the introduction of an unwanted microbe or toxin to a specimen that was collected. It could be the environment as well or equipment. Some examples are urine CNS resulting in a mixed growth from improper midstream collection, or it could be contamination to a surface in a room or shared equipment, which is one of the reasons why it's so important that we do that disinfection for any shared equipment, routine cleaning of shared spaces, and that high-touch surfaces cleaning as well. Next is the colonization. So this is when microorganisms are on or in a host, but not causing an active infection. So examples of a microorganism that may colonize but not infect is MRSA and C. difficile. Lastly, infection. So this is actually when that microorganism invades beyond our protective barrier, causing signs and symptoms of an infection. So examples are C. auris, wound infection with drainage. Other example is an infection from C. difficile, an individual having diarrhea, fever, and cramping, having those signs and symptoms. So what are the differences between colonization, contamination, and infection, and where do they actually overlap? So let's briefly review what the differences are. So at the top here, we have infection, and which is a pathogen that invades past that natural barrier, just like we were talking about before. So there's actually seeing signs and symptoms. Next to the right, we have colonization, which is a pathogen that is innately present on our natural barriers. Lastly, we have contamination. So these are unintended introduction of a pathogen or infectious material to the site that's actually being tested. So those are the differences. And the one thing that they have in common that you can see here in the center is that a microorganism has been identified on the specimen testing. So now we're actually going to go into each of these in a bit more depth. So first here, we have colonization. So did you know that being a resident of a long-term care home or congregate living setting is one of the major risk factors for being colonized with a multi-drug resistant organism? Here are some other statistics. So we have that colonization for MRSA in long-term care exceeds 50% versus only 5 to 10% of home patients. Colonization of multi-drug resistant gram-negative bacilli is about 20 to 30%. Residents may remain colonized even after the resolution of an active infection. So persistent colonization increases the likelihood of developing an infection. And lastly here, case definitions truly do help to avoid counting a colonization when we're looking at infection rates. So examples of colonizing bacteria are methicillin-resistant Staphylococcus aureus, which may colonize the skin and mucous membranes. We also have vancomycin-resistant Enterococcus, may colonize the GI/GU tract. We have extended spectrum beta-lactamase, which may colonize the GI and GU tract as well. And lastly, C. difficile may colonize the GI tract. So contamination. The definition, again, is the presence of an organism that was not present at the site being tested. So rather, the organism has been introduced from another bodily site, from the environment, or in the laboratory. So something that we were discussing previously as well. So contamination of the environment. So a comprehensive IPAC program should include measures to prevent environmental contamination of items such as the in-room computers, public computer keyboards, touchscreen, therapy equipment, etc. The program should consider increased traffic flow and traffic patterns throughout the long-term care home by staff, residents, and visitors. So really keeping in mind also those high-touch surfaces, so doorknobs, elevator buttons, handrails, things like that. So contamination of a specimen. So contamination is commonly associated with improper specimen collection, such as urine cultures. So for example, not utilizing a clean catch or stale collection for that urine culture could potentially contaminate that specimen. Wound swabs, so taking a specimen from other sites rather than that wound bed. Third, here we have blood cultures, so that improper cleaning of skin or the top of the collection container can also cause contamination of that specimen. So we could have also the contamination after the specimen was collected. So we could have cross-contamination. So that is, so part of this, one of the specimen was transferred into another. And this could occur from other samples if they were improperly stored, if they have cracks, or improperly handled. Okay, so this is question 5. So we're going to do a few questions on this topic that we were just covering. So the first one here, you received results from a urine culture for an 80-year-old female with dysteria. The culture report reads mixed growth. Which type of result does this best represent? A, infection, B, contamination, C, colonization, or D, positive result requiring treatment. So I'll give you a second there just to think about what the answer possibly could be. Okay, so the answer is B, contamination. So thinking back to our definitions that we just went over, contamination occurs when there is an unintended introduction of a pathogen or infectious material at the site that's being tested. So in this circumstance, the specimen was likely contaminated due to improper collection technique. So if we see that the lab result is saying mixed growth, that helps to signal that there was potentially some sort of contamination to that specimen. Question 6. Your healthy resident is positive for MRSA on a combined pooled nasal, rectal, and axillary swab being admitted to the hospital. Which type of result does this represent? So again, thinking back to those definitions and what we were just talking about, would be A, infection, B, contamination, C, colonization, or D, a negative result. So just take a moment to think about that. So the answer is C, colonization. So remember that a pooled swab represents colonization of MRSA on the skin and mucosal membranes in asymptomatic residents. So the key item to think about for this question stem, that would help you to answer would have been that the resident is asymptomatic. However, they're still positive for MRSA. And if this was an infection, as we know, we would be seeing those signs and symptoms. So last question here. You received a positive wound swab result for MSSA, which is methicillin-sensitive Staphylococcus aureus, from Miss Day's chronic venous ulcer. On inspection, you notice her ulcer has significant swelling, redness, purulence, and is now very painful for the resident. So these observations and result best represent A, an infection, B, contamination, C, colonization, or D, normal findings for this type of ulcer? So the answer is A, infection. So Ms. Day has symptoms that were reported. They have redness, swelling, and pain, and these are common findings for a skin infection. The culture is positive for a solitary skin microbe commonly associated with infection, so suggesting an accurate result. Okay, so this brings us to the end of our presentation, and we're going to bring this all together. So to improve antibiotic use in long-term care, it's important that we implement the 4-moment framework that we talked about earlier. Stephanie went through those 4 moments in detail for you. And in order to support the implementation, there are 3 critical areas to focus on. So the first one that we want to focus on is developing and improving your antibiotic stewardship program. Second is creating a culture of safety around antibiotic prescribing in your facility. And lastly, learning and disseminating best practices for common infectious disease syndromes. So these will all help you to apply the 4 moments framework for all residents receiving antibiotics and therefore improve antibiotic prescribing. So that comes to the end of our presentation. Thank you all for listening.
Thank you guys for that wonderful presentation. Bella, I really like when you describe each of the 7 core elements of the antimicrobial stewardship program. And Stephanie, I also love how you differentiated prophylactic, empiric, and therapeutic antimicrobial use and providing examples for each type of the antimicrobial use. I also found it helpful when you talk about antimicrobial susceptibility testing, the difference between susceptible, intermediate, and resistant, and how it actually looks like in an agar plate. And Chantal, finally, great job for explaining and providing examples for contamination, colonization, and infection. The Venn diagram showing the differences and overlaps between these 3 terms is very helpful in order to solidify what all these terms means. Thanks again to the UHN IPAC Hub team for your time and effort in teaching everyone about antimicrobial stewardship program. I sure learned a lot, and I'm sure the IPAC leads did as well. Thanks everyone for attending this, and we will all see you on the next one. Bye for now.